CT perfusion has been in use for quite a number of years, though we've all noticed the recent drastic increase in utilization. In the past, we've relied predominantly on visual interpretation of the perfusion maps to assess ischemic and oligemic states, but recent advances in artificial intelligence and advanced computation has brought into clinical use such tools as automated threshold maps and calculation of volumes of underperfused tissues, and this has allowed quick and accurate identification of patients who might benefit from intervention. However, I do think with ease of use can come complacency, and I hope to convince you that there is more information in the perfusion maps than you can glean just from looking at these automated threshold outputs, and hopefully we can marry the two together. Here's a brief outline of the topics we're going to cover today. A few things I'm not going to necessarily touch on. I'm not going to spend too much time on acute large vessel occlusion, threshold choices, pro and con of perfusion as a tool for acute stroke. These are complete topics unto themselves. I'm not going to talk too much about processing techniques. I'm not going to touch on artifacts or technical pitfalls. And a few indications for CT perfusion outside of the acute stroke setting are other topics that we're not going to get into today. A brief overview of perfusion physiology. Cerebral perfusion pressure is equal to mean arterial blood pressure minus intracranial pressure. In turn, the CBF is directly proportional to perfusion pressure, but inversely related to cerebrovascular resistance. And CBF is the key determinant in ischemia, tissue function, and cell death within the brain. Any change in cerebral perfusion pressure can then be compensated by arteriolar constriction or dilation, which serves to maintain cerebral blood flow. This works very well between arterial pressures of about 50 to 150, but anything outside this range has the potential to exceed the limits of autoregulation, and here pathologic CBF states can occur. So how do we measure perfusion with CT? On the left are the arterial input function and the voxel-specific time attenuation curve, and on the right is the residue function, derived by deconvolution of the tissue curve. This serves to reduce the effects of contrast delay and dispersion, and in essence, Tmax on this graph reflects contrast delay between the AIF voxel and the tissue voxel, or if contralateral, then the delay between what would be a normal AIF and the tissue voxel, therefore incorporating some macrovascular effects. And you can see where the other parameters are derived on these two graphs. So this brings up the concept of macro versus microcirculation. When we say macrocirculation, we sort of mean everything between the IV catheter and the cerebral arterioles. For example, a venous occlusion or stenosis, low cardiac output, or arterial occlusion or stenosis. Any changes in these factors will be reflected in the Tmax and similar time-based parameters. This does not necessarily predict tissue perfusion, however, and what we need to look at is the microcirculation, which refers to the capillary level perfusion. This is measured by mean transit time, CBF, and CBV, which are able to somewhat isolate the microcirculation, and this is the best measure of tissue perfusion, particularly in the setting of ischemia. Here's a really great table put together by Aaron Field, showing the 5 different perfusion states that we can identify on our standard perfusion maps. The top line in green indicates a case where there's something causing a delay of contrast arrival to the tissue voxel, yet due to collateral pathways there is sufficient perfusion pressure such that tissues are seeing essentially normal perfusion. Line 2 is in yellow. Now the perfusion pressure has dropped and the arterioles have compensated through dilation, and so we see an increase in cerebral blood volume to maintain normal flow. This is the case of successful autoregulation. On the third line, we have ischemia or tissue at risk. The Tmax and MTT are elevated, and the cerebral blood flow now falls because we have exceeded the limits of autoregulation. And in red, we have what we call infarct core, with a severe decrease in blood flow. These are tissues that are infarcted or bound to infarct without the chance of salvage. The final category is hyperperfusion, which we will cover shortly. So the important thing here is that if you're looking at the threshold overlay report, you're going to pick up these 2 states, the ischemic and infarcted states, but you will completely miss the other 3 states, and these can provide important information about the patient. Again, I'm not going to spend too much time on this, but in a patient with acute large vessel occlusion, you can see a pattern like this, which delineates the volumes of core infarct and penumbra, and we're all quite familiar with this. But what I want to do is move on to some sort of related conditions. So we'll start with stenosis. This can refer to either intracranial or extracranial stenosis, and the cause is sort of can vary. Doesn't really affect the way we're going to discuss this, but atherosclerosis, moya-moya vasculitis, vasospasm, which itself can be seen in subarachnoid hemorrhage, meningitis, RCVS, drug use such as cocaine or methamphetamine. And the perfusion patterns under this can span the same spectrum that we saw before. And let me give you an example or two here. A patient with left arm weakness. The patient had a severe stenosis in the cervical ICA on the right side, but no other significant occlusion or stenosis. We see here in the right hemisphere a fairly extensive area of increased Tmax, indicating some delay. Whereas if you look at the other maps in this same area, they seem to be pretty normal. So this would be our green category, the adequate collateral circulation. Now there is a small area posteriorly here demonstrating characteristics of core infarction. And indeed, on the subsequent diffusion-weighted imaging, there was only a small infarct corresponding to this area. Here's a patient with bilateral disease. The patient presented with acute left-sided weakness, and indeed, there is a right MCA M1 segment occlusion. At the same time, we see severe stenosis of the left M1 segment. On perfusion, we see the right side, the typical features of LVO with mix of ischemic penumbra and anteriorly a small area of core infarction. On the left, we see a large area of mild Tmax delay and perhaps some mild areas of increased MTT and CBF. I do want to point out the goal here is not necessarily to parse out collaterals versus autoregulation, but more just to demonstrate evidence that this stenosis has some hemodynamic effects that may increase the likelihood that it could be symptomatic. The patient received IV TPA, and in fact there was some MCA recanalization on the right and a few small infarcts, but no infarct on the left. So chronic occlusion of either intracranial or extracranial arteries is a fairly common finding on acute stroke imaging. By its very nature of being chronic, these are more likely to present with the milder degrees of perfusion changes, but certainly there can be true acute ischemia if perhaps the patient were hypotensive or if the patient developed disease in other arteries, limiting the availability of collateral circulation. This patient presented with acute left-sided weakness. The patient had a known chronic right cervical ICA occlusion, and there was no other occlusion or stenosis. The perfusion study shows pretty convincing evidence of compensated oligemia. The Tmax is prolonged throughout the right hemisphere, and there was a large area of increased cerebral blood volume, while anteriorly we see a little bit more normalized CBV and perhaps mildly decreased CBF, so we could be hitting up against the limit of autoregulation here, and perhaps setting foot into the ischemic territory. This patient had a contraindication to TPA, but did receive permissive hypertension, and in fact only a few small infarcts are seen on DWI. Moving on to luxury perfusion, you'll see here a graph similar to the one I showed earlier demonstrating the normal autoregulatory response. But remember, this happens in normal physiologic conditions, but in ischemic or infarcted tissues, this mechanism can be disrupted. On this new graph, the dotted line shows an example of disrupted autoregulation. So now there becomes more of a direct correlation between perfusion pressure and blood flow. When you combine this with recanalization and reperfusion of the infarcted territory, you'll actually get a case where CBF increases in excess of metabolic needs, and this is referred to as luxury perfusion. On the perfusion maps, this shows up quite the opposite as ischemia. The Tmax is shortened, the CBV and CBF are increased. MTT can also increase, and this may be confounded with coexistent loss of the blood-brain barrier integrity and contrast leakage. But you can see this pattern not only in patients who have already been treated for stroke, but even on initial imaging where perhaps there's a spontaneous recanalization, and this may explain some perfusion changes in patients with TIA, for example. Here's a patient with left facial droop. The patient had occlusion of a right MCA M2 branch. On the first round of perfusion imaging, there was what looked like a area of core infarction in the right frontal lobe, and in fact this was already evident on CT, as you can see on the left images here. This all matched, and the patient Did receive IV TPA, but was not a candidate for thrombectomy because of the completed infarct. So the patient was discharged and then came back 2 weeks later with altered mental status. CTA showed at this time the prior occluded vessel was recanalized, and on the same image you can actually see some gyriform areas of parenchymal enhancement, which is typical for subacute infarction in this stage. Perfusion now shows decrease in Tmax and an increase in CBF and CBV, corresponding exactly to the area of prior infarction, and this is the typical pattern of luxury perfusion. Transient ischemic attack is defined as an acute neurologic deficit that resolves within a short period of time. And if you look at these patients and identify those with no large vessel occlusion and no DWI lesion, actually 20 to 35% of these patients will have some changes on perfusion imaging. And these can fall into two categories. You might see ischemia or oligemia, for example, identified by a prolonged Tmax, or you can see more of the luxury perfusion type of picture like we showed in the last slide. I'm not going to show any more cases like this. It's similar to many of the ones we've seen before. The next topic, just briefly, is diaschesis. This refers to changes in function, metabolism, and perfusion in parts of the brain remote from a focal lesion, such as acute infarction. Most common is cross-cerebellar diaschesis, where hypoperfusion is seen in the contralateral cerebellar hemisphere, such as in this patient with acute left MCA territory infarction. A second pattern seen here on the lower images, the patient had a right MCA infarction, and on the same side a decrease in thalamic perfusion, which could not be explained by the vascular imaging, and which did not result in infarction. So this was a case of ipsilateral thalamic diaschesis. A couple of other types have been described, thalamocortical and transhemispheric. I haven't seen any imaging correlate to these, so I suppose the likelihood of picking one up is small, but something to be aware of anyway. Anatomic variants generally are not causes of ischemia, unless exacerbated by other concurrent diseases, but you can see perfusion asymmetry with a pattern of adequate collaterals. One you could certainly see on perfusion imaging would be fetal PCA. Congenitally absent ICA or ACA segment are also possible, though I haven't seen these demonstrated on imaging. Fetal PCA again. So in at least some patients, the posterior circulation can have a slightly longer Tmax than the anterior circulation in normal patients. So therefore, if you get a fetal PCA where one side is receiving more of an anterior circulation like perfusion, then that will result in some asymmetry. So in fact, this can mimic a contralateral delay if you're not careful, but in fact, what we're just seeing is better described as asymmetry. Here's a patient with a large left PCOM fetal type configuration, and in fact there's the left PCA territory sort of demonstrates the same degree of Tmax as the rest of the anterior circulation, whereas on the right there's a slight delay which looks more like our normal patient up at the top here. So just something to watch out for. And not to confuse for acute PCA ischemia, or at least to correlate with the side of the patient's symptoms before you try to diagnose any oligemia. Vascular malformations can present with acute symptoms, starting with AVM. These can be quite striking on perfusion. Certainly the voxels located within the nidus and feeding vessels, and draining vessels in fact, will demonstrate a marked increase in CBF. But there are changes in the actual surrounding tissues to be aware of. Number one, first pattern would be the arterial steal phenomenon. So this is typically just in the tissues immediately surrounding the nidus. You'll see a decrease in cerebral blood volume and blood flow, where the blood is preferentially shunted into the lesion rather than into the normal tissue perfusion. The second pattern would be venous congestion. As there's increase in venous pressure due to the shunting, there can be sort of a back pressure resulting in increased mean transit time and increased cerebral blood volume, and this can be remote from the nidus. Dural AV fistula, by its nature, it causes symptoms through the venous congestion and increased venous pressure. So the pattern here would be similar to the second pattern described in AVM. Developmental venous anomaly is certainly a very common vascular malformation. Once thought to be benign, but now we know that there can be outflow stenosis resulting in venous congestion. And in fact, some DVAs are known to demonstrate arteriovenous shunting. And either one of these can result in symptomatic presentation with headache, focal deficit, or seizure. And perhaps 8% of DVAs may show perfusion changes. I'm just going to mention this as a parenthetical. Dural venous sinus thrombosis and stenosis can also result in perfusion changes, most commonly a congestion pattern similar to above. Here are two examples from the literature. On the left, an AVM with a large nidus and some hypoperfusion in the surrounding tissues due to arterial steal phenomenon. On the right, a dural AV fistula with increased cerebral blood volume in the left hemisphere as a result of venous congestion. I didn't see in the literature any examples using the Tmax map, so I'm including a case from my institution here. There's a right perisylvian AVM, and in much of the right hemisphere we see prolonged Tmax as well as MTT, and this again is evidence of venous congestion. So developmental venous anomaly, this patient had transient left facial droop. There was no LVO, there was no infarct. We can see a large DVA in the right frontal lobe. And actually on perfusion, certainly we see the red within the vessel itself, but there's a sizable wedge here of increased CBF and CBV in the right frontal lobe. So this may reflect some of the changes that we discussed earlier. And in fact, if you look carefully at the source images in this perfusion study, on image 1, there is not yet any venous enhancement. Image 2, the DVA has a bit of enhancement in advance of any other venous structure. And in image 3, the superior sagittal sinus is now enhanced, so possibly some arterial shunting in this case. Neoplasms are not uncommon findings in acute stroke patients. And while I said I wouldn't get into characterization too much, here are just 3 examples. In the top left, a glioblastoma that had pretty striking increase in blood volume. In the top right, a fairly large meningioma, very, very hot on the cerebral blood flow and blood volume, and quite prolonged Tmax, sort of in a mother-in-law type pattern. And on the bottom, a non-small cell lung cancer metastasis, where the enhancing lesion itself was fairly bright on CBV, whereas the surrounding tissues were edematous tissues had a lower cerebral blood volume. You could certainly argue in those former cases that perfusion didn't add too much, but in this case I think it would. This 49-year-old male presented with aphasia, and I don't think I would really fault anyone for calling this head CT normal, but the perfusion is certainly not normal. And in the left frontal lobe we see this area of pretty striking increase in CBF, CBV, and in fact the Tmax is decreased. The patient went on to MRI, and this lesion is now evident on FLAIR. There's a little bit of faint peripheral enhancement here, but I think already you would be worried about a higher grade lesion due to the perfusion pattern. And in fact, in unfortunately just 5 months, this progressed quite a bit, and this was a glioblastoma with a wild type IDH gene, which makes sense with the aggressive pattern that we have seen here. Seizure is a very common feature in patients presenting with acute neurologic deficits, whether the seizure was witnessed or suspected or not suspected. We all know that ictal and interictal perfusion changes have been well studied for many, many years. And conventionally, in the nuclear imaging realm, we talk about the ictal period demonstrating increased perfusion and the interictal period demonstrating decreased perfusion. It's not quite so straightforward in acute stroke patients because some of these patients may have subclinical seizures, or in fact may have ongoing seizures in non-convulsive status epilepticus. So even if the physician does not describe convulsions at the time of the imaging, you might still see an increased perfusion pattern rather than an interictal pattern. Here's an example of a patient who had previously had skull-base surgery due to an ethmoid carcinoma, and the patient presented with acute aphasia and right hand weakness after a documented seizure. And there was no LVO, but the patient did have decreased perfusion in the left frontal lobe. There's a prolonged Tmax, there's a decreased CBF and CPV. And then interestingly, the same patient came back 2 weeks later with acute aphasia. In this case, there was ongoing seizure activity on the admission EEG, and we see in not only the same territory that was hypoperfused before, but even more extensive, we see this large area of low Tmax, high CBF, hyperperfusion, so more of an ictal pattern due to the ongoing seizure activity. This is a patient with metastatic lung cancer, sort of more of just a interesting case due to its striking features. The patient presented with altered mental status, seizures, and encephalopathy. We see quite severe decrease in perfusion in both frontal lobes, extending somewhat into the parietal lobes. So this perhaps is a case of postictal hypoperfusion encephalopathy, perhaps with a component of vascular dysregulation, which I'm going to talk about next. Not only in ischemic states, but in a number of other states, the regulatory mechanism can fail or can act in opposition to its normal expected function. So we would say insufficient or inappropriate changes in vascular resistance, leading to low or high perfusion. So not only acute and subacute infarction with luxury perfusion, also hypoxic ischemic encephalopathy. Press is this is perhaps thought to be one of the most likely mechanisms for press, especially in those related to hypertension, where the cerebral perfusion pressure actually exceeds the autoregulatory limits. Traumatic brain injury has a component of dysregulation, as does migraine, at least in the traditional view, but we'll get to some more updated thoughts on that in just. Here are two separate examples of press from the literature. On the left side, you see increased blood flow and blood volume in both posterior hemispheres, whereas on the right side, you see a decrease in cerebral blood volume in the posterior hemispheres corresponding to the flare abnormalities. So, it's not always clear the exact precise mechanism of press, but dysregulation, whether causing an increase or decreased perfusion, is certainly at least some component of it. So the last topic I want to cover is something called cortical spreading depression or cortical spreading depolarization. This was first described in the 1940s by a Brazilian physiologist, Dr. Liao, while working with rabbit brains at Harvard, and was only much later in the 90s confirmed to occur in humans. He found that after stimulating one part of the brain, he would see waves of electrical depression spreading along contiguous areas, followed by restored EEG activity in the same wave-like pattern. A key detail here is that this spreads through adjacent cells, not through synaptic connections. These are slow-moving waves, especially in gyrated brains like primates and pigs. In humans, the waves actually propagate perhaps only half a millimeter to a few millimeters per minute. And this is actually caused by a very drastic degree of cell depolarization. In fact, the loss of membrane potential energy in cases of cortical spreading depolarization is many thousands of times more than the energy spent on a normal synaptic impulse, and even exceeds the depolarization we see in seizures by a factor of 5 or 6. This has been described as a twilight state close to cell death, and in fact, if tissue ATP reserves are depleted, then cell death will follow. In addition, spreading depressions are accompanied by vascular changes, and it's not entirely clear whether this is a response or a cause, but there are waves of vasodilation and vasoconstriction. Here's a really neat optical imaging example in the brain of a pig. In the bottom right image, a drop of potassium solution was used to stimulate one point in the brain, and then you see these slow waves of perfusion changes. This video is about 2 hours of recording compressed into around 40 seconds. This phenomenon has been implicated either in theory or by direct experimental evidence to be associated with a number of different diseases. Migraine with aura was probably the first conjectured and one of the first proven relationships with spreading depression. In the conventional teaching, this disease was thought to be a result of vasoconstriction causing the aura symptoms, followed by vasodilation causing the headache. This is now thought to be an incomplete or imperfect model, and it's likely these spreading depolarizations in visual, speech, or motor areas cause the aura, and as they march down across the trigeminal nuclei or back up into the pain sensory areas, that they may cause the headache symptoms. Delayed cerebral ischemia and subarachnoid hemorrhage is probably related to this phenomenon. We know it's not a simple case of vasoconstriction causing ischemia, though this is certainly a contributing factor. Secondary brain injury following trauma is associated with spreading depolarization. In ischemic stroke, it's been shown, at least in animal models, that these depolarization waves can start in the penumbra tissues and spread out to other parts of the brain. Cerebral hemorrhage can cause this phenomenon. In PRESS, there may be a component of spreading depolarization. Seizure, it's not only the seizure itself, but the secondary phenomenon of spreading depolarization that may be responsible for brain injury. It's been theorized that hippocampal depolarization waves might be a factor in transient global amnesia, and there could be other associations. As we discussed, spreading depolarization may contribute to further brain injury, which is why this is an important topic of research, especially in these traumatic brain injury and subarachnoid hemorrhage patients. So this is a therapeutic target. Ketamine has been shown to stop depolarization waves. Lamotrigine seems to prevent aura in migraine patients, and this is a suspected mechanism. So the CT perfusion correlate, we're obviously seeing on perfusion more of a snapshot of a wave of vascular changes. So it's possible to see either increased or decreased perfusion. In migraine with aura, both increased and decreased perfusion patterns have been described. Here's a patient with a known history of migraines who presented on this occasion with transient aphasia and dizziness, followed by headache. She had no large vessel occlusion or stenosis and no infarct on the subsequent MRI, but the perfusion study shows a delay in Tmax in the posterior left cerebral hemisphere. So this appears to reflect changes related to her migraine aura and maybe an imaging correlate of cortical spreading depression. And in fact, it's perhaps the only imaging correlate of spreading depression. So in conclusion, what I want to say is that first and foremost, ischemia and infarction are certainly the targets of perfusion imaging in acute stroke. But if you combine the tool of threshold overlays with an interpretation of the perfusion maps, you can drastically increase the nuance of description of ischemic and oligemic states, as well as contribute to identifying alternative diagnoses in a number of cases. And we also touched on cortical spreading depression, and due to its implication in quite a number of diseases, and the fact that perfusion is at present probably the only imaging method we have to glimpse this vast field, it's certainly an area ripe for research and clinical application.